Discover which brain regions are active during acute and chronic pain. Stay tuned because today you will learn how to use the sensory motor system to reset pain perception networks and stimulate descending inhibition of pain. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. I'm honored to welcome our next guest expert, Dr. Jason Smith, clinic owner of Utah Spine and Brain. Dr. Smith is fellowship trained in vestibular rehabilitation, brain injury rehab, and earned a Master of Science degree in clinical neuroscience. Today, he's teaching us a functional neuroscience approach to chronic pain syndromes. Dr. Jason, thank you so much for joining us on the Virtual Neurology Summit. We're excited to learn from you. Please take it away.
Thank you so much for having me today. It's really exciting to be able to share. I'm Dr. Jason Smith, and I am pleased to be sharing with you today something called, entitled Chronic Pain, the Dark Side of Plasticity. And you'll see two images here. And of course, the dark side is something we all want to avoid. But when people suffer chronic pain, we'll find out that there's definitely a dark side to it. So the first, I just want to share with you two cases. One is from a 1995 study in the British Medical Journal. And the second is a patient case that I worked with myself. But this first case is a simple, just a little snippet in a BMJ in 1995. And there's a worker, a roofer, who was climbing down a ladder, and he basically stepped onto a 15-centimeter nail. It shoots through his steel-toed boot and goes through his foot, and he's in severe pain. So his buddies and coworkers take him to the emergency room, and they try to get the nail out at the hospital, can't do it. He's in so much pain, he's in agony. And what they finally did is they drugged him up so he couldn't feel hardly anything, pulled the nail out, finally got his boot. They were going to do some drastic repair procedure on his foot. And they look at his foot, even though that nail was proximal to the steel, it actually went between his toes and his foot was totally fine. But he was in so much pain that he couldn't even function. And so it's interesting when you talk about what pain is, there's a chronic side and an acute side, but it can be very frustrating as a practitioner. And that's one of the most common reasons people come to us. There's many others, but that's one of the probably main reasons I see. And, just thought I'd, look at pain from a different way. We got Wesley from The Princess Bride, who just says life is pain. And, we've got Kevin on The King of Queens, who is just, suffering some horrible scenario. But why do we even have pain? Well, if you look at that study I just showed a minute ago, pain's basically a conscious motivator to protect us. And it's related to internal and external stimulus. But the interesting thing about pain, it's not truly only from a physical cause. So what happens is, if we have any type of cognitive or emotional or social factor, we look at people who like to play, dangerous games or, sports, and you'll have pain as you go through it, but you sometimes don't even feel it till later. If you look at the research there's certain conditions where certain patients aren't even able to feel pain at all, and they usually die early. I had a friend when I was growing up that had this weird scenario, and he didn't feel pain. He would smash his hand in the door, smash it in a folding chair. He wouldn't even feel it. So he ended up dying of an appendicitis at about age 22. So people who don't feel pain, we need it, but we don't like it. So, why do we have it? Visual illusions exist. They're fun. But there's also this rubber hand illusion, the pain illusion, and it's fun unless it's your real hand. So I like to read about pain and how to image it, how to study it, how to quantify it. And I read this quote from Cal Newport in Deep Work, and he says, "Clarity about what matters provides clarity about what does not." And how does that apply to us? Well, when we look at acute pain, we define it as something that lasts, less than 2 months. It can have a potential tissue damage or an actual tissue damage. You don't actually have to, as that British Medical Journal study taught us. But persistent pain that lasts over 3 months long after the noxious stimuli is removed, is something that as many people deal with. So obviously, I just put together this chart for you to study at your leisure. But the key is there's simple examples of acute pain that we all understand. We can strain our neck, get whiplash. We can sprain our ankle, tear some ligaments. We can have surgery and have pain from that. We can burn ourselves. We can just have emotional pain. But in terms of the chronic pain syndromes, there's fibromyalgia, chronic regional pain syndrome, and myofascial pain, and all the autoimmune diseases can cause pain as well. So let's go to the next. One of the most interesting books that I've found is an old book from like 1875, and it's from an old doctor named Silas Mitchell, and he was studying a lot of the veterans from the Civil War who were shot with balls, and they were injured. And what he found was that the ones who had their nerves injured had vastly different pain scenarios than the other just standard injuries. And so you can look up this study, gunshot wounds and other injuries of the nerves. And he's basically the first person who delineated and quantified this neuropathic type of pain called chronic regional pain syndrome. Used to be called something else, but I'm forgetting that name at this very moment. But complex regional pain syndrome is something we see fairly often, but it's very severe. It starts with a pain sympathetic response, usually from some kind of trauma. I've seen it from fractures. I've seen it from blast injuries, from traumatic brain injuries, from surgery. And you get the sympathetic response with muscle spasm and actually the endothelium spasms, and then it causes this sympathetic response where you just get massive swelling and burning and pain. So it's pretty severe. Now, I just want to talk just a minute about the feedback loops of pain. One example of a positive feedback loop is, the birthing process. And the positive feedback loops takes us from one spot to another. Negative feedback loops tend to help us have homeostasis. So with the pain cycle, we have some injury, there on the right of that chart. It causes some muscle spasm. You don't move it because it hurts. And then you get decreased movement, and then you have more weakness and atrophy, and then you still have to move. So it just cycles around. So the positive feedback loop in pain is something that needs to be broken, because if it doesn't, it will just perpetuate indefinitely. Now, I'm not going to go very detailed into the ascending pathways of pain, but needless to say, there's several different pathways, and they all involve the brainstem, and they end up in the cortex. If you notice, in the first two on the left, they both go up through the pons, and in the third one on the right, it goes up through the midbrain. So those are different patterns that get sent up through the periphery. Now, the thing that probably interests me the most is the thing called descending modulation of pain. And the descending modulation, it can happen from our anterior cingulate, it can happen from our frontal lobe, but specifically in our brainstem, we have these different regions that actually send signals downward to the spinal cord where the pain comes in, and you can suppress pain long before it even comes in if you do it appropriately. So let's go and let's talk about the negative feedback loops really quick. Just an analogy is body temperature. It helps us maintain homeostasis. If our body temperature gets over 37 degrees Celsius, then suddenly our temperature center in the hypothalamus says, we got to kick in. We're going to start activating some sweat glands. The water comes out, the water evaporates, and then we bring that back down. So that's an example of a negative feedback loop. The problem is in the body, many of our feedback loops are positive. So they just keep perpetuating, and they keep creating more and more pain. In terms of chronic regional pain syndrome, there's three types. We're not going to go into it specifically today. I just wanted to have you be able to see that. There's types where there's no major nerve damage. There's types where there's significant nerve damage. And then there's this other unique criteria called not otherwise specified. So here's a few pictures of some cases that you can see. One side is affected dramatically with the swelling and the burning and the redness, and the other side is basically normal. So we know there's an asymmetry that happens with this chronic issue. And then there's another one of the hand. This is a friend of my patient who basically had an article written about her, and she felt like she was being burned alive with the CRPS. My patient that I saw was her name was Melanie, and she was a soldier. And in May 2012, she had a rocket explode 5 feet from her while she was in Afghanistan. She had shrapnel throughout her spine and legs. She had ACL surgery a few years later. And about 2 weeks after that, that's when her CRPS pain started. So she was a patient at the VA in Salt Lake and was just suffering dramatically. She was losing weight dramatically. She had so much pain that she couldn't eat. She couldn't basically function. She was given about a year to live, and they said, basically, there's nothing we can do for you. So she ended up doing some treatment in Arkansas with a doctor who specializes in CRPS, and she was released after about 12 weeks with absolutely no pain, which was exciting. I didn't meet her until June of 2019 when she had a relapse and was back in Salt Lake City. She called my office and asked if she could please be seen because she was going to go to the emergency room or kill herself, one or the other. And my staff found a way to get her in. But when she came in, she was in so much pain. I couldn't touch her. I couldn't move anything. And she said, even if you touch, I just had a light tissue. I touched it on her skin. She says, it feels like you're burning with a blowtorch. So she said, even putting on jeans feels like there's 1,000 razor blades cutting her up and down her legs. Okay, so here you see her walking just right before we did any type of exam, which I really couldn't do because she was just in so much pain.
Come back.
And if you look at she looks like
sort of normal for you.
Yeah.
It almost looks like she's had a stroke or she's had something.
I also have a mobility dog.
Okay.
That helps me.
So that's the first video. So let me show you, I'll show you the post. So now you see her walking. This is literally 7 minutes later after we tested some things and found some things.
Yeah.
Basically,
That's a difference, huh?
Now do your ABCs.
It's a total,
every other letter.
Total transformation.
A.
And we were dual tasking her to see how she did. She actually hesitated for a second, but now her arms are swinging. She's moving, she's gliding, she looks like a human again. And I love that little half smile there at the end. She was so grateful. So basically what we find with chronic pain is that chronic pain literally hijacks part of our brain. And it hijacks not just the area that perceives the location of the pain, but other areas, the visual areas, the emotional areas, the sensory areas, even other areas that control our heart rate and our breathing. And if you look at this healthy image to the right, you'll see that there's all this, this blood flow and function right where it's supposed to be. And if you look at someone who has chronic pain, it's now dysfunctional. And if you read the book, The Brain That Chases Itself, you'll find that Moskowitz had severe chronic pain and he couldn't get out of it for years and years. And what he found is that when he was in ramping up pain, he would just use imagery, and imagery would help him slowly just have a few minutes of relief from his pain. After several weeks, he was able to go, or actually after several months, he was able to go 15 to 20 minutes without pain. And after a year, he was completely pain-free. So you can read about that story more in The Brain That Chases Itself, written by Norman Doidge, an MD. But I just thought it was so cool to look at the different areas of mapping that is changing from chronic pain. One little image here that I wanted to share with you shows the yellow shows the primary sensory and motor areas. It's a very small component of our brain. The association cortices on the left, all the blue is everything that's associating. And so those blue areas get hijacked when you have chronic pain. And what we want to do is use several different strategies to recover those functions in our brain. So here's an example. If you've searched and learned about somatotopic maps, you've all seen this. These maps help certain events happen together. You'll see on this right where the hand is, it's close to the face. And that's probably because when babies are learning to explore their world, they put everything in their mouth. So their hands and their mouth form a map that's very close to each other. Here's another map on the deep cerebellar nuclei, some somatotopic maps in the cerebellum, and also the superior colliculus in the upper brainstem. So you can find these maps in multiple areas, and the way that this brain changes when you're having chronic pain is that basically those maps are lost or altered, we'll say. And so what I did with Melanie to get that change, I couldn't touch her, I couldn't adjust her, I couldn't stretch her. She literally was having so much firing or pain that I had to use something that I discovered from Deanne Fitzgerald in Wisconsin. And she taught me this thing called bilateral nasal occlusion, binasal occlusion. And basically what you do is you just put some glasses on and you use Scotch tape or electrical tape and just fit that tape over the medial part of the eye. I usually angle it a little bit like it's in this presentation, in this image, so that when people look down, the eyes diverge. So you can just see that. And that's exactly what I did with Melanie. And it literally had a dramatic effect. And I've used it numerous times in brain injury cases, stroke cases, chronic carpal tunnel, chronic elbow syndromes, all sorts of different things. And literally putting that on, you just test some biomarker. It could be strength, could be gait, could be breathing, and then you retest it. And you'll be surprised how dramatically that changes. So another application that I like to use, and I'm only covering 2 today. I have a little slide of several others you can research into if you're interested, but this is mirror therapy. And Ramachandran basically invented this therapy about 25 years ago. And that study listed at the bottom is the Cochrane database study of every single it's a systematic review of every single paper that's been published on mirror therapy, which is also known as graded motor imagery. And it's only about 248 pages, but it's a nice read if you're interested. But what I've used it for is people who've had strokes, people who've had brain injuries, and even when people have chronic elbow pain or wrist pain, you can literally use this mirror and repattern the brain, and it's sometimes instantaneous. So what you do is you say someone has chronic left hand pain in this image, you put the hand that's affected, that's painful, behind the mirror, and then you look at the reflection of your normal hand in the image of the mirror, and then you just basically move it around. You can do it up and down. You can wiggle your fingers. You can have someone help you and do a stroking inside the mirror and outside of the mirror. And all of a sudden, if you play the game and let the illusion work on you, you'll notice your pain will go down. Now, Dr. Rosenthal from Dallas, Texas, taught me this other method because it takes a few weeks to get your mirror box coming in. You can also just use any mirror and cover it with a blanket if you want. But he taught me that if you take a picture of someone's painful hand or whatever body part it is and just show that to them, some crazy thing happens and it literally changes the amount of pain that someone experienced. I've seen people go from 8 out of 10 pain to 4 out of 10 pain just by looking at a picture of their painful body part. It floored me when I saw it. Another way to do it is to take a video of the healthy body part. Say the left wrist hurts. You can do a video of the right wrist, and then you just have them watch that video of them moving their healthy hand and pretend it's a mirror. And they literally watch that, and the pain will sometimes go to 0. The brain is a fascinating organ. And then I have another little app that I use to help people practice this at home, where it just shows different images of the right hand, the left hand, up and down. And you'll see if you have patients practice that, it literally helps take that hijacked brain from chronic pain and recover those brain areas. So let me just summarize. Functional rehab, it's not complex. Most of it we're already doing. We just have to take a thorough chief complaint history, find out what goals are limited, observe and inspect and find out where that lesion is coming from. And then as you do your examination, I like to decide what are the top 3 areas that are involved. Usually it's cerebellum, brainstem, and frontal lobe. Occasionally there's some the occipital lobe and parietal lobe that's affected with specific impacts, but those are the 3 I find are highly involved. And then I just give it a try. Try the BNO, the binasal occlusion, try the mirror therapy, and then just retest. And you'll be surprised, as your patients will, when you all of a sudden get their pain to come down in just a few moments. And they just have to practice it, and it'll become permanent. So I just like to always remind my patients and the doctors we talk to that rehabilitation success completely on the intensity of the therapy, how often we do it, and then making sure that we can make it fun for the patient. If we make it fun, they have a lot more chance that they're going to do it. A lot of people ask me, well, how long does it take to completely change these neural maps? Well, they're getting changed every day. There's research studies that are mentioned by Kaza Merzenik, and they found that the somatosensory cortex was reorganized just after about 4 to 5 months in the raccoons and in the squirrel monkeys. They were literally able to change that in just a few months. So if you can get a small short-term change and use some of these strategies, I mentioned binasal occlusion and mirror box there on the fourth, but there's other things you can do. Hyperbaric ATM2 is something that's been fantastic in my office and very immediate. And then just finding what dysfunction people have and just testing. Be willing to fail, because that's how we grow. And I think that's pretty much the summary is from Socrates: the only true wisdom is knowing you know nothing. And I'm just really excited to be able to be in the process of making a difference for patients as I make a difference for myself and my family.
Absolutely. They call it practice for a reason. It's a clinical discovery always, every day. Thank you so much for this excellent presentation. I'm going to do a quick summary and then a couple questions.
Okay.
So you started by talking about chronic pain, the dark side of neuroplasticity, which is such an interesting way of saying it because it's so true. And it can happen quickly and it can really hijack the brain, like you mentioned. You started with an example of a 29-year-old builder, the patient who had stepped on the nail, and pain made it impossible to function, even if the patient was objectively fine, but it makes it impossible to function. So why we need pain? We need it from conscious motivator to protect ourselves, clearly related to both external and internal stimuli. It's modulated by other inputs like cognitive, emotional, social factors, and we really need it for survival so that we, for example, take the nail out of the foot, or so that we don't have an appendix issue that we can't feel and don't realize the severity. With acute pain, it's potential or actual tissue damage, unpleasant sensory and emotional response that lasts for less than about 3 months period of time. Chronic is going to be variable intensity, persistent, and recurrent. With nerve pain, results in different pain expression when it's neuropathic. And then you went through complex regional pain syndrome. And so we have the pain impulse to a sympathetic nervous system response to vessel spasm to swelling of the tissues. And as you mentioned, this positive feedback loop. So you gave the example of, for example, the birthing process is a positive feedback loop. It's going to continue moving forward. It's going to keep cycling. Now, what's hard to deal with for patients, and something that we need to be aware of as practitioners, is that the same thing or similar is happening with pain, that it's a positive feedback loop. So we have decreased movement to weakness, to atrophy, to pain and spasm, to reduced motion and circulation. And this will continue to perpetuate if it's not interrupted. So that's really where we come in understanding those descending pain pathways. So for example, the brainstem and cortex pathways have, ascending pathways are going to be the brain up to the brainstem and the cortex via the pons in the midbrain. And then descending pain modulation can start with the anterior cingulate and the frontal lobe and goes through the brainstem. The brainstem can suppress pain. A negative feedback loop is going to be like, for example, body temperature to maintain homeostasis. And then you gave us such an excellent example. Thank you for showing those videos. My goodness, I couldn't believe when you said it was 7 seconds later, after doing one therapy, to watch somebody's entire physiology change by working with their neurology is truly fundamental. It's amazing. So incredible case example there. You went through pain and neuroplasticity, how it hijacks the brain, actually 15% of visual processing, and the brain that changes itself, imagery helps with relief. So with cortical territories, the association cortices can become hijacked with chronic pain. The brain maps can become blurred, if you will. Somatotopic maps both in the cerebellum as well as the colliculus as well as the cortices. And then what you did with the patient, you went through binasal occlusion, mirror therapy, and then graded motor imagery. Thank you for making that so practical. These are all things that we can walk away with and utilize with patients instantaneously. And as you put it together at the end with the key steps, it's about taking a history, understanding the patient's goals, what's restricted, what's inhibited, observe, do an examination. And then I love this piece right here of localizing it to 3 areas of the brain. So sometimes neurology can feel a bit overwhelming, especially when you're seeing a patient patient who has a lot of symptoms like that case example that you gave, where you felt like you could, I mean, she couldn't even be touched. It felt like, needles when just by wearing jeans or, it was that intense pain. So starting with 3 areas of the brain, and then do a trial of the treatment to activate the brain, and then retest and see the result that you get. Assess fuel delivery, and then make goals and recommendations. And then you wrapped it up by saying intensity of therapy, repetition, and of course, making it fun. And then neural maps are changing every day. Now, you did take the question right out of my mouth is, how often to do treatment. So we know that the neural maps are consistently changing, and which is good. That means that we can instantly see results. Now, when it comes to neuroplasticity, and I know that it's going to be patient specific, so there's no definite answer on this question, but when you see somebody who's had chronic pain and you start working with them, how often in between their visits during the day would you normally have them do their rehabilitation at home? So how, like 5 times per day, 1 time per day, what would be a typical frequency for a chronic pain patient?
So what I usually do is I like to get those pulse oximeters, and it measures the heart rate, the ones that are live feeding, not the ones that just do it and then show you a number. I like the ones that are constantly showing you your heartbeat. And I look at that, and I'll do, say, 30 seconds of a therapy, and I'll just watch their heart rate. And as long as their heart rate is slightly going down or staying the same, I'm good. And I'll actually have them go through a full minute or 2 of that unique therapy and just watch what they do. If they tolerate that fine, I'm like, okay, do this 5 times a day. And I just like to I'd rather have them do 2 minutes 5 times a day than have them do 10 minutes straight and fail and say, it hurts me too bad. I know if I measure the heart rate that they're going to be able to tolerate 2 minutes. And it's just gapping that throughout the day. I'll tell them, you have my permission. If I tell you to do it 10 times and you only feel like you have enough energy and to do it 5, then do it 5. But I want you to do it more than once a day. So most of the time it's 3 to 5 times per day. And sometimes people want to just, they want to get going faster because they're like, look how good I'm doing.
Yeah.
No, you have to, less is more.
Yes.
It's counterintuitive sometimes, but I find that I have to teach patients that less is more. And all the problems we see are when patients start to feel good so quick and they suddenly go back to all their other activities. And now they're recovering for 2-3 weeks. So I would say 3 to 10 times a day based on the heart rate. And it's 1 to 2 minutes. And it might be 1 or 2 exercises. And I eventually have them do 5 or 8 exercises that we know work. But I've had a lot of success just doing short exercises, and it's doable.
Yes.
And I have them keep track. I like them to have a streak. So like, let's see if we can do this 10 days in a row. All right. And then we just start going, all right, you got 10. Let's see if we can make it 20. And pretty soon they're like, yeah, I got a streak of 37 days. Oh, I messed up. I missed a day. I'm like, don't worry. You got 37 out of 38. Keep it going.
Yes.
We just try to make them get that positive reinforcement. And I live an example. I do the same thing. I have streaks playing the guitar over 895 days, studying Chinese I'm over 1,000 days now.
Wow.
So I've been doing things and I'm living this example to the patient. So I know it's possible.
Yes, you live the advice you give. Thank you
Yes.
for that response. That's amazing. I love that you've objectified how to determine their level of neural fatigue. So when they're hitting that neural fatigue point, so that we can stay just under it, but we can continue to challenge the system throughout the day. And it's going to be patient specific how many times they can do it per day, always. But by having that objective analysis, we can see how long they can tolerate before going to the point of neural fatigue. Excellent.
Yeah.
Thank you so much for this excellent presentation today. We learned so much from you. We appreciate you joining us on the Virtual Neurology Summit. And for all of our viewers who are tuning in, thank you so much for being here and for committing your time to always learning the newest strategies, the best way of evaluating your patients to ultimately get the best brain-based results. I'm Dr. Krista, founder of the American Posture Institute and your host of the Virtual Neurology Summit, and we'll see you on the next masterclass.